When the 2014 publication of the guidelines for ACC in terms of lipid control were published, one of the main aspects of this whole thing is the lipid discussion that a doctor has with a patient, this risk discussion. The implementation of the guidelines really hinges on this factor. Doctors talk to their patients all the time. Why is this different? Well, we're talking about having the risk discussion here, and I'm with Dr. Michael Joseph Blaha, MD, MPH, the Director of Clinical Research, and you're Assistant Professor of Medicine at Johns Hopkins, correct?
That's right.
And this is an April 7th issue of JACC. It's Clinician-Patient Risk Discussion for Atherosclerotic Cardiovascular Disease Prevention, the importance to the implementation of the 2013 ACC guidelines, which were published in 2014. Like I said, doctors talk to their patients all the time. Why is this one different?
Well, I think one of the centerpieces of the new guidelines was putting front and center the clinician-patient risk discussion so that treatment with the statin isn't mandatory at any level of risk or lipid levels in the new guidelines. They give recommendations of when statins seem to have a net benefit, but then you have to have that discussion with the patient to have shared decision-making, respecting patient preferences before you treat with the statin.
It's probably good practice because many of the guidelines now talk about that shared decision-making. It's being emphasized over and over again. So how do you have the conversation and what is part of the conversation?
That's right. Yeah, so guidelines have always said, it's more of a guideline than a rule, but this puts it front and center, and that's a great aspect of the new guidelines. What it says is to start with the new 10-year ASCVD risk estimator. That's the starting point to figure out if a patient's high enough risk or not to have that discussion about treating with the statin. Then we talk about other risk factors. Can we treat other risk factors first? Then we talk about lifestyle, that's diet and exercise. And then we get to the part we discuss statins. And if your risk is high enough, let's say about 5% or 7.5% 10-year CVD risk, we have that discussion about statins. And that includes talking about adverse effects, diabetes and muscle, drug-drug interactions, as well as patient beliefs and preferences about risk reduction in cardiovascular medicine.
In many cases, it's pretty much a dichotomous decision. It's, yes, you are at risk, no, you're not at risk, but it's that third area that actually comes in that's not dichotomous, where you have to decide where does this person fall? How does the conversation help guide that?
Yeah. What it does is it allows us to tell patients that we're not always sure about cardiovascular risk estimation, right? The new guidelines have been under fire because of accuracy of the new risk estimator, and maybe it overestimates risk. This allows us to say to patients, we think this is your risk, but we may be wrong a little bit. So let's talk about this and see if we think that you're high enough risk to benefit from a statin. And in some cases, we're going to advise the possibility of other tests, such as a coronary artery calcium score, or sometimes a high sensitivity C-reactive protein, to further define risk so that that patient feels comfortable with that individualized risk estimate, and they can make a decision whether they think statins are in their favor or not. And they're part of the discussion there, and therefore it's not a mandatory thing that we treat the statin, but it's part of the risk discussion.
In terms of your paper, if I remember right, I think it's the first table that really runs down this list that you and I just talked about, so doctors need to check that out and follow that along. What else is in there that could be of help to them?
We talk about some easy, practical ways of talking to patients about certain things like adverse effects of statins or drug-drug interactions or the benefit of statins. Because if patients are engaged and understand that we've acknowledged the fact that statins have some minor adverse effects, and we understand the benefits and can describe them in a very specific way, they're engaged in that decision and much more likely to take the medicine. So check out the paper to look for how to talk to your patient about diabetes, how to talk to your patient about myalgias or muscle pains, but also how to talk to your patient about the benefits of statins versus the risks, where in most cases, in the patients we're going to be discussing, the benefits outweigh the risks. But you have to have that discussion with the patient to get them engaged in that shared decision model.
And it's an ongoing conversation, but it's this first initial risk discussion that is of great importance, correct?
It's a vital importance, because I think patients sometimes think we give them statins without thinking, right? Or we want to put them in the drinking water.
Right.
This acknowledges the fact that it is a shared model. We're not always certain about risks. Sometimes we need to think even more closely about risk with like a coronary calcium score. And we can say to our patients that we know that you're going to get more likely to get a net benefit than a net harm from these drugs. And I think they're much more likely to think that the patient involved them in the process. And this is going to be a part of all guidelines in the future, where we really front and center involve that patient, and documents like ours that inform physicians how to use the guidelines, how to implement them, are going to be vital, I think, to care.
Well, successful implementation of this particular guideline and probably many others are going to depend on this risk discussion and the success of it. And so this is in the April 7th, 2015 issue of JACC. It is really worthwhile, if for nothing else, than that table that really gives you an opportunity to look at how to have this particular risk discussion. For CardioSource World News, I'm Executive Editor Rick McGuire.